So let's just look at stats for California of the births in California in the year 2011. And just to quickly go over it, so they're saying that in general, the studies pretty much range between 15 and 23% of all women experience depression in the perinatal period. And that's quite a significant number, and as I mentioned, there's a range because there are different tools that are used in the studies. But these have been, there's been many studies that have been done that clearly say we have to pay attention to this. And as I say, as of late, we're starting to look more in anxiety. The next one is especially striking because if we look, these are the number of births in California in 2011 that are paid by Medi-Cal, which is a surrogate for poverty. So for women in low socioeconomic classes and also teens, up to 33% studies are shown, and some even higher, are diagnosed with perinatal depression. That's a third. And the other issue with teens to keep in mind is that what we're seeing for them is that very often their depression, because of the developmental time of life and their own cognitive development, we are seeing them having symptoms of clinical depression 4 years out. So for those of you working with young moms, there really is even a lot more work to be done and more critical intervention to be done between moms and babies. The other studies are starting to show is that women depressed at 18 weeks have 3 times the risk of postpartum depression, and at 32 weeks, 6 times the risk of postpartum depression. And so this really speaks to the idea of screening in pregnancy when there is no babe in arms, and screening at different times, ideally, basically in an ideal world. So let's just quickly look at this, and this is just postpartum depression. Now remember, there's really a lot on it. We're just going to look at a couple of these symptoms. But the DSM-5, by the way, is coming out this month. But I want to focus on these are just symptoms, and just notice this is just for diagnostic purposes and for billing purposes for psychiatric disorders. But just notice, just quickly look at these and try to imagine yourself perhaps in them. Okay, Cynthia, we can go to the next one. The next slide. I can. There we go. I'm going to just pick out a couple of the symptoms. And remember, symptoms and behaviors are just reflecting a state of being for the mom. So how would these particular issues influence how you work with a mom, her being able to follow a regime, perhaps nutritional changes, lifestyle changes? These are really significant ones. Marked diminished interest or pleasure in most or all activities of life. Feelings of worthlessness or inappropriate guilt, hopelessness, and despair. Despair is something that will pretty much stop us in our tracks, and is one that tends to be frightening for any of us working with moms. And it also speaks to intervening with a mom, perhaps who is depressed, and sort of saying an idea of, you really need to do better with this. Now, there's a way to say that, but I mean a way that we may come perhaps at her a bit too hard is not going to work if a mom is in a particular state. There also is diminished concentration or indecisiveness, and that's going to make it hard for a mom to perhaps concentrate on what you're trying to teach her that isn't really even related to literacy. And then there's a tendency, there's fatigue and loss of energy, and then there's a tendency to isolate. None of these things are really good for well-being, but I just want to focus on these and just muse a bit about how would this affect your work. And once again, you know, this is just really for folks that have experienced anxiety, and it's just degrees of anxiety. We're not talking about degrees or severity. But think of how this particular state of being is going to affect a woman that you're trying to teach certain information that perhaps may be seen as complex. It also tells you there may be something that you want to look at. Or if a mom constantly comes in with yet another question of something that she's worried about. And very often at times we get tired of it. We either sometimes can get perky with it, or sometimes we get burdened by it. And it often takes us to just say, I can really see that you're very worried about this. What comes up in your mind? Once we start asking a mom that way, then we don't have to work so hard. And then there may be, we can refer her back to her OBGYN, et cetera, et cetera. But if you find that you're constantly answering questions and feeling like it's never ending, you could be dealing with a mom whose level of anxiety is such because of pregnancy losses, because of many things, because of the burdens of her life, that interferes with the work that you're trying to do with her. Okay, the next slide is consequences of untreated PMAD, and especially anxiety. And these are studies that are coming out that are also getting attention, that we're seeing constriction in the placental blood supply, that the cortisol levels are affecting the startle responses in the newborn. The babies have, newborns have a hard time being consoled, and that certainly isn't a very good mix for a mom who may already be pressured, perhaps is isolated, or in the case of teen moms. I mean, it's not a good thing for either of them. So then that, and this is not the discussion for the day, today it's the issue of medicating. How do we medicate? And there's many, many more studies that are coming out on the use of psychotropics, and also issues of, there's a lot of research done on relaxation techniques, meditation, and other psychopharmacological interventions that can be done. Okay. I want us to stop looking at pathology for a minute. We're now on a slide about well-being, and that is, what is well-being? And if you go to the CDC, you will find this definition of what is well-being, and that really is, in our work, this is really how we should be keeping our eye on the prize, is the issue of well-being. I'm going to just move down here to the idea of quality ties with others are significant. And if you think of times in your life that you've really experienced well-being and contentment, you will see that these issues were definitely operating. Also the ability to manage complexity, and you can see how that could be tough in following the regimes that some of our moms have to handle. So self-acceptance requires a lot of work on our part as professionals, in terms of a mom accepting what she is able to do, and ourselves being able to accept what she is able to do versus what we may feel she needs to do for perhaps our agenda or our concerns, obviously, about the baby. The next slide is factors in well-being: pursuit of meaningful goals, growth and development as a person, etc. The idea that people, this last quote is by someone who works a lot with depressed moms and babies. Everybody needs somebody crazy about them. And the idea that how can we express some caring for the moms with which we work, and how does that then assist us in the education that we're trying to do with her. And I would suggest that if we forget this piece, it's going to be very difficult to do the work that you have in mind for them in your diabetes work. Okay. Depression and anxiety, when they're significant, are really illnesses of dysregulation. They're affect dysregulation, and they will dysregulate us. And no one likes to be in an uncomfortable state. And so we do many things to get ourselves away from it. There's also multiple studies that are out on, before one does anything with a mom experiencing some degree of depression or anxiety, and any of its other cohorts, that we have to regulate ourselves, because we will be affected by it. And so how do we do that? And I ask you to think about, how do you regulate yourself about that? Often it's a matter of reminding ourselves that we don't have to fix it, that how do we ourselves take care of each other, and we can maybe address this in some questions. But it often takes us knowing that we're going to have to say to the mom, how are you today? And in doing that, just know that not all we really have to do, is that what we have to do is bear witness, and to be as present and as grounded with it as I can. I really can't use more scientific words with that, and I hope you understand what I mean. You're bearing witness. You don't have to fix it. It's not our life. I mean, we can be caring, we can try to find supports, but the issue of we're just being present as much as we can, and we allow that state to come into the office and into the clinic setting. In addition to doing the idea of doing our educational work, because it's present whether we want to acknowledge it or not, and it will show itself in behaviors that mom can do or cannot do. So let's look at the idea of, we're getting all these recommendations on screening. So why do we want to screen? This is a lovely poster that comes out of Wisconsin, and it basically says which mom is depressed. You can't really tell by looking. And it also shows that there's every ethnic group is recognized. And a mom will quickly pick up from you if you want to know about it or not, if you really want to know about how she feels or not. And so a mom can definitely put up a good look if everybody is telling her how wonderful it is, etc. And then when she's home, it can be a totally different picture. So let's look at one of the screens that is widely used, and that's the Edinburgh postnatal depression screen. And there's, just to point out, it's pronounced Edinburgh because it comes from Edinburgh, Scotland. So, and it's been around since the 80s. And the Edinburgh, you will see if you go to websites for ACOG and the AAP, you'll notice that they recommend screening. They tend to get a bit of a debate about screening tools, but you will hear the Edinburgh used, brought up in many journals from different disciplines. It's simple because it only has 10 questions, and it screens both for anxiety and depression. It doesn't diagnose depression, and I really have to tell you, often folks get scared because they say it's going to diagnose depression and we don't have a psychiatrist around. It only looks at symptoms, okay? I believe you were sent, Cynthia, you were sent a copy of the Edinburgh, and if it's possible for you to look at it, it's going to make a bit more sense to you right now. If you can look at the Edinburgh, if you have that.
Yes, I did receive it.
Great. Okay, and so if you can, and we're not going to go over especially the scoring, but you'll see that each question, and this you'll see it's in the past week, basically says, how have you been feeling in the past 7 days? And number one is, I've been able to laugh and see the funny side of things, and then there is scoring for each of the mom's answers. You briefly may want to look at this. Number three is that one about worthiness. I blamed myself unnecessarily when things went wrong. 4, 5, and 6 sort of speak to anxiety, and that's one of the reasons for a good, quick, and dirty tool. The Edinburgh is good because it addresses the issue of anxiety. Let's see, let's go down. And then the last one we'll talk a little bit about is number 10, which is the thought of harming myself has occurred to me. And that is usually the one that gets us kind of frightened, because now we're starting to be talking about potential suicide or thoughts of suicide, and certainly that gets into complicated media portrayal of infanticide, et cetera, which starts to color our own reactions to things. It doesn't trump clinical judgment. It doesn't identify somatic symptoms, which is sometimes an issue with certain cultural groups and certain ethnic groups who more just talk about psychological distress in terms of the state of their bodies. And some people, that's how we describe ourselves, is in terms of how our stomach, my stomach feels squirrely, it's moving all around, I feel like my body's in concrete. So the Edinburgh, it basically is, basically doesn't address that. And any screening tool is best presented and is only as good as the way with which it is presented. So I'd like to mention that. So the score is tallied. And I have an asterisk by these scoring numbers. For example, the second one down is score of 9 to 12 in the total for the Edinburgh score. And once again, I don't expect this to be really solid for you. Is that in recent literature from when the Guidelines for Care was written up, we're finding out for certain minority groups like Latinos, African American women, we have to be even more conservative with the scoring, that the burdens of their life requires us that if they get a score, for example, of 8 or 9, we need to pay attention to it.